Hi everyone. My name is Samrad Ghavimi. I'm a fifth year urology resident here at UBC. Thank you for joining me this morning to talk about a topic that is quite important, but perhaps not spoken of too commonly. It's basically, going through my 5 years of residency, we see so many different patients of different backgrounds and different needs, and more, especially after my chief residency block, I kept on thinking about, once these patients go home, once they're, out of the hospital, what does their life look like? I remember Dr. Black at one point said, there's patients who have life before an ileal conduit and after not ileal conduit. So for these grand rounds, I really want to perhaps shed light on a potentially dark topic to think about and talk about. So everybody to some degree is familiar with this picture, the CANMEDS portfolio. Essentially, it defines necessary competencies for all medical practice to provide a foundation for practice in Canada. And, as urologists, we touch on each of these domains, but the main domain that we'd be considered for is medical experts, consultants, individuals that receive referrals from primary care. And as medical experts in the field of urology, the expectation is that we provide high quality, safe, patient-centered care. And that involves collecting relevant information, making clinical decisions, ordering necessary diagnostic, or recommending necessary therapeutic interventions within our scope. And part of that collecting relevant information is sometimes, collecting an appropriate social history, getting a full picture of the person that has been referred to you, which sometimes can get overlooked in the process of assessing a patient. Now, this is, in some capacity, everybody's kind of seen something like this, I'd imagine, known as the wellness wheel. Basically, the idea behind it is, one cannot be healthy or well if you're not well in multiple domains. This is just one adaptation that I picked up from the Princeton University website. And some of it's very intuitive. You can think of what they mean. For example, physical wellness. If you get injured, you go seek medical care to fix the injury. If you're sick, you take the appropriate medication. Even for our post-op patients, things like nutrition. For certain procedures, we have ERAS protocols to try to make sure that their nutrition, their mobility, and those kinds of things are looked after. If they have mobility issues, we have the physiotherapist, occupational therapist, and those resources available. But for emotional well-being, that's an important component of mental health. Coping with a diagnosis, coping with the procedure, coping with the recovery, and the stressors that come with it. And we don't always have the best strategy to deal with that, and we don't always have the best resources to deal with that. So that's something that I hope to talk about today. So in terms of objectives, my hope is to discuss and recognize prevalence of mental health concerns in a surgical patient. I'm not sure what that blue line is doing there. I want to look at the literature on the impacts, particularly of oncologic diagnoses and treatments on mental health. I'm doing a fellowship in oncology next year, and I was very curious to see these patients that have oncologic procedures and require treatment and long-term follow-up. What do they look like after surgery? And hopefully discuss some strategies to diagnose mental health concerns and liaise with mental health experts. Now, this is probably the toughest part, and this is the most challenging thing to accomplish. But nevertheless, I'm hoping that at least having a conversation about it will allow us to have better strategies moving forward. So generally speaking, mental health is something that affects everyone. This is something that affects 1 in 5 Canadians in a given year. This is likely also underreported because not everyone seeks out help. Not everyone goes and shares their struggles to get the appropriate care. By age 40, and this is pretty staggering, about half of Canadians will have had or do have a mental illness that they're dealing with. So that's a pretty significant proportion of individuals that will have a mental health concern. And this is something that can impact everyone, but certainly systemic inequalities are a risk factor, and that would be poverty, homelessness, discrimination, all of those can worsen given experience and the severity of presentation. MDD, or major depressive disorder, impacts about 5.4% of the Canadian population. Again, this is most likely underreported. Anxiety disorder is 4.6%, and you have 1% of bipolar disorders and 1% of schizophrenia prevalence in the population. And on average in Canada, there's 4,000 suicides per year. So you work out the math, that's about 11 suicides a day. So certainly high numbers to consider. Now, in the field of urology, oftentimes we may be, even though we're not primary care providers, a lot of the times with certain conditions, we may be the ones that patients really turn to for help. And lower urinary tract symptoms, for example, can be quite bothersome and cause significant psychosocial distress. And depending on the study you look at, there's association of depression with less ranging from 6 to 21% of patients, anxiety, 3 to 10% of patients associated with lower urinary tract symptoms. About 1 in 10 men with erectile dysfunction suffer from depression. And again, depending on the literature and where you look, 2.5 to 37% of patients have anxiety. 50% of men with Peyronie's disease suffer from depressive symptoms, and this increases the risk of substance use disorder, anxiety disorder, self-injury behavior. So this is a lot of general urology presentations that are associated with significant mental health concerns. So what are some barriers to care? So obviously urology deals with both male and female patients, but the general aspect of urology, a lot of times the proportion of male patients will be significantly higher than female patients. So the barriers I'm going to speak of in a paper written by Elterman focuses on the male population, but that's not ignoring the fact that female patients are also quite prevalent in the urology practice. So one of the barriers to care that he discussed is the stigma to receiving care. So estimation, of course, about 4 million men live with mental illness, but they're likely not accurate, as again, they're likely to be underreported, as they're much less likely than their female counterparts to present with a mental health issue, underlying masculine ideals of strength and self-reliance, making them avoid care. Men typically are different in emotional expression. They're more likely to manifest depression as anger, aggression, or violent behavior rather than sadness, and put on a tough exterior mask. And because of this, screening is often quite challenging and may miss men's presentations of mental health issues. And they also tend to think that healthcare professionals will think less of them as if they're weak if they present with a mental health concern. When faced with options to seek help, in which their perception would change the masculine identity, men are more likely to turn to drugs, alcohol, work excessively, engage in infidelity. And when these mechanisms inevitably fail, they can become risks for self-harm, particularly suicide. And sometimes, and this applies to both men and women, simply not knowing what services are out there and how they can access it and how it can be helpful. This could be a big barrier to receiving care. Just going back to the third point of maladaptive coping, I think that is the start of one thing that I want to make sure I drive home today is, when you have a patient you've been following for a while and you notice that their behaviors change in terms of, the day-to-day, their drug activity and things like that, those can be cues to kind of have your spider senses tingle that something may be going on that's not necessarily clear as you'd like it to be. Now, general cancer obviously goes without saying has a significant impact on the mental health of patients. Patients that are diagnosed with cancer are about twice as likely to commit suicide. 70% of suicide patients over the age of 60 have attributed factors to a physical illness, cancer being one of them. And we see high suicide rates in patients with lung, oropharyngeal, breast, and pancreatic cancer. It's not necessarily surprising given that these cancers tend to be diagnosed at later stages and more advanced, which can obviously have an impact on mental health. But what about urologic cancers? Now, going through residency, and I spoke with a couple of residents too, there's this perception, and I'd always hear the discussion of patients that have penile cancer, penile treatment, they're super high risk for mental health concerns and suicide and things like that. And when I dove into the literature, It surprised me a little bit. It surprised me a little bit in terms of what cancers are very prevalent in certain aspects and what maybe are not. And I'll go into the details about this. So I expected to find a little bit more on penile cancer, but regardless, I'll dive into that as my first literature review of urologic cancer and its impact on mental health. So this is a study that was done by Simpson and colleagues, and they analyzed suicide risk in patients with penile cancer in the literature, and they used the surveillance epidemiology and end results SEER database, which identified 6,155 patients with penile cancer from 1973 to 2013. So that's over 40 years and only 6,000 patients, which kind of speaks to how rare this cancer can be. And so not a lot of great data available. But they looked at multiple demographic variables such as age, relationship status, race, along with clinical pathologic variables, including histologic grade, staging, such as localized, regional, distant disease, or unstaged. And they had a simple question: primary outcome, yes or no to suicide. So they found that 90% of patients underwent some form of surgery. 13 patients, 0.2% of patients committed suicide. Interestingly, 11 of the 13 patients were married and 2 were single, divorced, or widowed. What they found is that age and white race showed an increased risk of suicide. And just for clarity, SMR is the standardized mortality ratio, which is basically suicide rates compared to the general US population. Of interest, they found an inverse relationship to being married and suicide risk. So basically, if you were married, you had a direct correlation. You had an increased risk of committing suicide, which is a little bit different than the other cancers that I'll speak of very shortly. Also a bit different findings in terms of the grade was that, grade 1 may have had an increased risk of suicide compared to grade 2. And you can see that grade 4 didn't have an increased SMR, but this was also because there wasn't very many patients in this study and the analysis, which could certainly contribute to the finding. It is interesting, though, that they found, like I said on the last slide, that married patients did worse. This could be because, of the anatomy of the cancer, men feeling shameful, feeling like they're not able to satisfy their partners and things along those lines. The key thing here is that while the risks of suicide are compared to the general public are higher for penile cancer, perhaps it's not the one that will be the highest risk in the urologic presentation when it comes to cancer. And fortunately, it was lower than I expected in terms of rate. But, just because patients aren't committing suicide, that doesn't mean, a diagnosis of penile cancer is easy. There's many other aspects of their quality of life that's significantly impacted. So this was a study that was done that looked at systematic review of quality of life, psychosocial and psychosexual impacts on patients in penile cancer. And they looked at they assessed 437 studies, and only 6 were suitable for review. And their inclusion criteria was simply quantitative data on quality of life, sexual function, and psychological well-being. And taking out duplication of studies, they came to only 6 studies that met the criteria. And again, not a ton of patients, as you can see, again, speaking to the nature of the disease and how rare it is. 128 patients from the 6 studies, and the mean follow-up was about a year to 80 months. And the treatments that patients received were partial penectomy, total penectomy, glanectomy, or laser therapy. 5 of the studies were retrospective. 1 of them collected pre-treatment data on erectile function prior to disease and quality of life prior to disease and during disease, but it wasn't truly a prospective. So really, these are retrospective studies. These are the 6 studies that were chosen. And as you can see, there's no standardized way to acquire the quantitative data. A variety of questionnaires were used and data obtained in many different ways. For example, the GHQ, the General Health Questionnaire, HADS is the Hospital Anxiety and Depression Score. And these studies use different questionnaires and also different administration of assessment tools in how they collected their information. And what they found is when they looked at the General Health Questionnaire, about 37 to 40% of patients showed impairment of their well-being. In the Fakara study, they also showed more mutilating surgery resulted in more impaired well-being, as you could expect. Upjordsman was the only person that used a DSM score, which is where they assess the DSM-3R, which I think right now the DSM that's used in psychiatry, DSM-5, so this is a bit outdated, as you can imagine. But interestingly, they found that 53.3% of patients showed sign of mental illness, and 2 out of 30 had PTSD. 25% of patients showed signs of avoidance, and 40% also showed impaired well-being. So the takeaway here is that obviously there's not a ton of patients in these studies, and the data isn't strong, but we can see that quite a significant portion of these patients have impact on their mental well-being. And some of these studies, I mean, the one with the DSM shows over half of the patients showed mental health concerns. So it's something that we really have to be aware of when it comes to patients that have penile cancer, even after treatment. If their prognosis is good, that their mental health certainly can take a hit. So shifting gears a little bit to a study that I saw actually in many other papers that discussed, and this was in patients with prostate cancer. So this was a study by Ghavimi and colleagues in 2014, and it evaluated mental health issues, namely anxiety, depression, and suicide, in large population cohort of older men with prostate cancer. And they looked at predictors of mental health illness development and its association with 3 main treatment modalities, being radical prostatectomy, radiation therapy, and what they call watchful waiting. They used the SEER data and identified 50,856 men over the age of 65 between 1992 and 2005. Just to put a comparable, the penile cancer data was over 40 years, 6,000 patients. This one over 13 years, over 50,000 patients, just to show the difference in prevalence. They excluded patients with T3, T4 disease, unknown stage or grade. They excluded patients over the age of 80 and those who had metastatic disease. And of interest, they excluded patients who had underlying mental health conditions prior to diagnosis. And what they found is that about 20% of patients developed mental health illness in this study. And some factors that led to increased risk of developing mental health illness was being over the age of 75, a higher comorbidity list, getting treatment at a rural hospital, being single, divorced, and widowed, which is in contrast to what we saw in penile cancer, urinary incontinence, and later year of diagnosis. And more protective factors were Black or other race, ethnicity, very high income status. Interestingly, erectile dysfunction was protective in this case, and receiving definitive treatment. Now, erectile dysfunction, I mean, they kind of hypothesize that maybe because these patients are older and may not care as much about their erectile dysfunction. And other studies looked at long-term bother erectile dysfunction generally decreases, whereas if you have urinary incontinence, that bother increases over the years. One of the things that was a takeaway here was that patients who received treatment did better than those who were on watchful waiting, or I guess what we call active surveillance. Now, this could be because the timeline, perhaps, active surveillance has developed and evolved significantly over the years. So perhaps at the time there wasn't as much critical information relayed to patients. So patients were quite anxious about the fact that they had cancer and they weren't getting treated. Whereas those who received treatment may think, well, this is done, it's out of my body, and I'm cured. But it certainly was interesting. And the next study I'm going to talk about actually had a bit of a difference in finding in terms of patients who received treatment versus those that didn't. And this is actually a Canadian study from Toronto, and they did a retrospective study from 2002 to 2009 in Ontario men over 66 with non-metastatic prostate cancer. And they looked at radical prostatectomy, again, radiation therapy, and active surveillance, excluded patients who died within 5 years of prostate cancer or developed metastatic disease within 1 year. And they used the general public as a control, and propensity score matches 1 to 5, done to match age, comorbidities, and geography. And the primary outcome that they looked at was antidepressant prescriptions that were filled. So 41% of patients underwent radical prostatectomy. 41% also received radiation, and 17.6% were on active surveillance. And they performed a multivariable logistic and negative binomial model where they looked at different models at 1, 2, and 5 year period before and after treatment, and looked at the receipt of antidepressant prescription and days of supply per 1,000 person days. And what they found was patients that had surgery had a greater odd of receiving antidepressants compared with controls up to 5 years, with the greatest differential effect seen at 2 years. A significant increase in supply noted at 2 years, with peak relative increase of 33%. Patients who underwent radiation also had increased odds of receiving antidepressants with a peak ratio seen at 5 years, but they didn't see a significant change in receiving antidepressants for patients that were on active surveillance. Now, there's quite a few limitations to this study, retrospective, heterogeneous finding, and there's no true diagnosis of a mental health concern. There was no diagnosis of depression or anxiety. It was simply getting the antidepressant, not sure if it was given by a primary care physician or a psychiatrist. So there's a lot of questions to be asked in this study. And the key difference in this study compared to the last one was this one was the general public. The former looks at mental health. This was a larger study, looked at quite a lot of people, more and a bit later than the first one, in the sense that, like I said, I think active surveillance may have been improved in terms of what's done for follow-up. So patients may feel more like they're still looked at pretty closely, even though they're not receiving intervention. The biggest takeaway here, though, is, even though they have a bit of a difference in finding, the takeaway is that you are, regardless, getting diagnosed with prostate cancer, receiving one form of treatment or another, still at an increased risk of mental health illness and distress. And that's something that we should be keeping in mind for all of these patients. Now, what about patients who receive ADT? ADT has become a cornerstone for treatment of metastatic prostate cancer, and it helps improve survival in prostate cancer, but it's not without side effects, and that's described to patients. It's associated with bone fractures, cardiovascular disease, cognitive deficits. But what about mood? This was a study done by DECA that looked at deprivation therapy and depression in men with prostate cancer who were treated with definitive radiation therapy. Now, there's conflicting evidence generally in the literature when you look at ADT and its impact on mental health. Either there's a lack of control or the study population is quite heterogeneous or underpowered. So what this group tried to do is they tried to test the association between ADT and depression, looking at a homogeneous cohort of patients with localized prostate cancer who received radiation therapy with and without ADT. And they looked at veteran affairs, informatics, and used platforms that allowed them to access complete assessment of patients, development of depression, outpatient psychiatry assessment, inpatient psychiatry assessment, and suicide. And they looked at patients with non-metastatic prostate cancer from 2001 to 2015. And they, again, excluded pre-existing psychiatric conditions and use of psychiatric services prior to the study. And their primary outcome was looking at patients who developed depression, and secondary outcomes was use of outpatient psychiatric resources, inpatient psychiatric resources, and suicide. So they followed almost 40,000 patients over the years. 25,122 received radiation alone, 14,843 received radiation and ADT. Primary outcome of depression, they found 943 patients who were diagnosed with depression. And these are the secondary outcomes to follow. 7,825 used outpatient psychiatric services, so 1 in 5 patients. 358 used inpatient psychiatric services, 54 committed suicide. So that goes to show that depression isn't the only mental health concern that can arise from these kinds of conditions. And we see such a significant rise in outpatient psychiatric seeking compared to just depression diagnoses. This table I actually split into two because I had no other way of fitting it into a slide. But basically, what they did here is that this is a result of a base multivariable fine-grained regression model for development of depression, and their multivariable analysis showed that ADT was associated with the development of depression. Other risk factors were use of SSRI and serotonin modulator use. Older age, however, interestingly, was protective in this study from depression. Then they performed a sensitivity analysis, four different sensitivity analyses, with the first one being adjusted for propensity score in a fine grain model. Second one, they used time-varying ADT exposure. Third one, they excluded patients who developed depression in the first year of diagnosis, thinking that, this is something more long-term rather than an acute reaction to diagnosis. And the fourth one, they incorporated measures of disease severity into the diagnosis and mental health concerns. And interestingly, what they found in all four is they found that ADT was associated with depression and outpatient psychiatric utilization, but there wasn't an association with inpatient psychiatric utilization or suicide. So the big takeaway here is that ADT comes with risks to mental health, but psychiatric issues that require inpatient admission or suicide are not necessarily associated with ADT, but can simply come from the fact that cancer diagnosis is far from a benign process, and cancer is not just a physical diagnosis and process, and that we should be aware of the impacts it has on patients from a mental health perspective. Now, bladder cancer and the literature review, that it's kind of what I was expecting to see when I was looking at penile cancer from what I'd heard every time we had a patient. And I remember, and I think everyone in the program at some point or another when we were junior residents were told by the social worker and the CML, if there's a penile cancer patient, you got to let us know. You got to let us know. We got to have close follow up. But we never heard this about bladder cancer, and it was quite a lot of literature around bladder cancer and the impact it has on mental health. And this was actually an excellent review that was done over 18 years that looked at literature regarding prognostic implications of mental health on bladder cancer patients. And they discussed the impact of diagnosis and treatment of bladder cancer on the mental health of patients over time. And they looked at 87 publications, 19 of which were selected, and 11 of these studies were prospective, 8 of them were retrospective. And of the 19, 2 of the studies were on non-muscle invasive bladder cancer only. 11 of them were on muscle invasive bladder cancer, and 6 looked at both at the same time. And it was, again, it's an excellent review because it kind of encapsulated all the studies that I came across when I was doing my literature review. So I'll break this down into the findings of non-muscle invasive, muscle invasive, and the combined. So when it comes to the non-muscle invasive group, not as much literature compared to the muscle invasive group, but the 2 studies that was involved in this review was done by Schmidt and colleagues and Yoshimura and colleagues. And these were basically 2 prospective single cohort observational studies found. And they looked at the impact of diagnosis and treatment for both on mental health based on externally validated questionnaires, which include the short form 36, which basically contains 36 questions that assesses 8 aspects of physical and mental health. And the Schmidt study in particular, they looked at 244 patients and used the SF36 along with the bladder cancer index to measure mental health. They collected baseline scores obtained at the time of diagnosis at 6 months and 12 months follow-up, and they found a statistical significant worsening of mental health at baseline after diagnosis when compared to the general population. Interestingly, though, the mental health of patients seemed to have improved after transurethral resection of bladder tumor and intravesical therapy. Now, similarly, Yoshimura also looked at 133 patients who were evaluated with the SF36, but their findings were a bit different than Schmidt. They found that mental health was worse after the first TURBT, but it seemed to improve after repeated procedures. And this could be perhaps that early stages are more concerning about cancer, but as it proceeds and you require more treatments, there may be a level of acceptance from patients. That's just a hypothesis, I'm not sure. But it's also worth noting that the patients that seem to have, I guess, accepted it and coped better were ones who received 4 or more TURBTs, but that number of patients dropped from 133 to 34, so not as many patients. But the key takeaway, as expected, is that the diagnosis of cancer had significant impact alone on patient health, even before any treatment was started. Now, this is the bulk of the data, and this is where the significant data for bladder cancer comes from. And I split it into two different slides. And I won't go through every single one, but I'll go through some of the key ones that I found in the literature. So the first one here, Jazar, they did a retrospective analysis of the SEER database from 2002 to 2009 to assess the impact of psychiatric illness diagnosed after treatment on survival outcomes. And quite significantly, they found 50.4% of patients were diagnosed with psychiatric disorders after receiving treatment for bladder cancer. And you were at a 1.19 time risk of developing a psychiatric illness if you had a radical cystectomy done. Those that developed the mental illness showed significant worsening in overall survival and cancer-specific survival, outlining the importance of identification and recognition of mental illness in these patients to optimize their outcome. The study below, Asghari, they prospectively assessed patients who had ileal conduits versus continent diversion and found that at 2 months, there was better psychological and social status and sexual life in the continent diversion compared to ileal conduit, with general global satisfaction in the continent group. And this was corroborated by the study above by Yang and colleagues, who compared 54 orthotopic with 24 non-orthotopic diversions using the SF-36 questionnaire at 6, 12, and 24 months post-surgery, and found the mental health of patients was much more easily restored in the orthotopic group. Now, Benner's study showed that treatment isn't always anxiety relieving. They followed 33 patients at baseline, 2 months, 4 months, 6 months post-op, and they found that anxiety and depression symptoms identified at baseline didn't improve at 6 months, in spite of reassurance that the cancer was essentially cured. And once again, this highlights that cancer diagnosis carries significant anxiety that can be lifelong, lasting, and perhaps treatment of it may require other healthcare professionals to help us out. There was an interesting study done by Mohammed in 2014, and not a lot of patients, only 30 patients, but this was prospective, and they did patient interview study in 30 patients. So basically, they met with 30 patients to identify unmet needs after the diagnosis of muscle-invasive bladder cancer and radical cystectomy treatment. And patients discussed that the biggest concerns were insufficient discussion regarding diversion options, side effects, the recovery process, and what that would entail, and even self-reported unmet psychological needs up to 72 months after diagnosis. And this highlights the critical component of screening for emotional distress and diagnosis and treatment of muscle-invasive cancer, and sending the appropriate referrals as needed. And finally, Sharma, which is the second study, sorry, this is a little bit out of order, just based on different themes I wanted to discuss. Sharma study used the SF-36, or an abbreviated version of the SF-12, which basically was 12 questions to assess the mental and physical health scores pre-op of patients. Interestingly, they found an association with patients with low mental score and a 30-day complication rate. So if you had low mental scores prior to surgery, you are at a significantly higher risk of having a complication 30 days in. And this puts forth the question of the importance of self-appraisal of health status and its impact on the post-operative course. And this was corroborated. I don't have the paper here, but this was corroborated by a study that was done by Saxton and Balanovich, who looked at general surgery patients who had major abdominal surgery. There was 200 patients, I believe. And they found that low SF-36 scores were independent risk factors for a post-op complication over 200 patients in multivariable analysis. So knowing the patient and where they stand and where they're at mentally with what's going on, and even they may have had mental health concerns prior to this diagnosis, it's really important to know the full picture to have a better understanding of what their course is going to look like moving forward. I'll only chat about a couple of these because it is quite extensive, but I just wanted to chat about the first study here, Palapatu. They did a prospective analysis of 74 patients with organ-confined muscle-invasive bladder cancer, and they assessed for psychological distress prior to and 1 month after radical cystectomy and diversion. They determined pre-op and post-op stress scores using basic symptom inventory 18, BSI 18, to measure psychological domains of distress, anxiety, depression, and somatization. And they found 45% of these patients had psychological distress pre-op, prior to even having any procedure. And 1 month post-op, when the cancer was treated, they still had a third of patients, 34% of patients that remained in psychological distress, which once again notes that simply removing the cancer or curing the cancer from a physical perspective doesn't necessarily cure the patient of their illness. There's multiple factors in play. The last one I'll talk about here is Henningson, which they looked at the chronic symptoms of the patients have post-op on mental health after radical cystectomy and diversion. They basically collected information with anonymous postal questionnaires, and they, not surprisingly, found patients that had more symptoms and more side effects from procedure were more likely to have lower mood and worse mental health illness, which goes to show that sometimes these patients, they may be cured, but they may have lingering effects from surgery, and those shouldn't be ignored because it can significantly impair their day-to-day. The final aspect of the bladder cancer review was the papers that had a combination of non-muscle invasive and muscle invasive. And first one was a retrospective study of Smith and colleagues that looked at 535 patients, and they compared it to 770 control subjects, basically individuals in the general public with similar baseline characteristics, comorbidities, but no cancer. Of the 535, 458 had non-muscle invasive bladder cancer, 77 had muscle invasive. And after diagnosis, as you'd imagine, there's a significant decline in mental and social quality of life relative to control groups, particularly in the muscle invasive bladder cancer group. And patients who underwent radical cystectomy developed significant decline in many mental health domains, such as role emotion, vitality, and social functioning. One of the things that I want to tell, the last one I'll talk about on this slide is Lee and Wang basically looked at depression and anxiety in patients that were diagnosed with bladder cancer in Chinese patients. And they basically did a cross-sectional study of 327 patients with bladder cancer, both muscle invasive and non-muscle invasive, and significant prevalence of anxiety and of depression and anxiety being 78% and 71% in their study. Again, underlying the mental health hit that patients get when diagnosed with cancer. And finally, again, I won't go through the detail of this. This kind of illustrates, there's so much data that looks at bladder cancer and just what a hit it is on patients' quality of life, just from diagnosis alone. Even in the group that gets a non-muscle invasive diagnosis, oftentimes we're relieved when we see, low-grade non-muscle invasive on the pathology report, but we can't ignore the fact that these patients, it impacts them, and it stays with them. And there's a certain level of anxiety and depression that we may not necessarily see on follow-up, but should certainly seek out to make sure that they're coping well. Now, moving on from bladder cancer, this was a study that I looked at that basically looked at the suicide risk of patients with GU malignancies. The goal is to treat the patient's presentation and hopefully their overall state. So what are some factors we should be aware of when assessing a patient? In other words, are there certain characteristics or red flags that we need to be aware of that would predispose patients to worsening mental health concerns and subsequently potential suicide? And so this was a study that looked at incidence of suicide in patients with GU malignancies. And once again, they used a SEER database assessing patients with prostate, bladder, kidney, testes, and penile cancer from 1988 to 2010. They looked at patient sex, age, race, marital status, along with clinical pathological variables such as tumor stage and grade. The primary outcome they looked at was patient suicide and compared it to the general population. And they performed a multivariable regression model to generate odds ratio to identify risk factors of suicide of each malignancy. So there was over 1.2 million patients they found. Unfortunately, the absolute number of suicides, not high, 0.2% of patients. However, compared to the general population, you can see that the standardized mortality ratios increase with almost every single cancer in the GU system. Again, of interest, the penile cancer one was the one that was not increased. But once again, you see there's only 5 patients in the database, which reiterates how little data we have when it comes to assessing patients with penile cancer. But in their study, they also looked at specific characteristics or risk factors that were associated with higher risk. So patients who were under the age of 39 or over the age of 80 were at an increased risk of developing or committing suicide. Male sex in bladder cancer and kidney cancers were independent risk factors for suicide. Relationship status. So being in a relationship, being married was protective, except for in penile cancer, as we saw that earlier on as well. There was an increased risk of suicide if you were married. The white race, particularly in prostate, bladder, and kidney cancer, was an independent risk factor. In not undergoing surgery and distant metastases were independent risk factors. So patients who did not receive surgery for their diagnosis were at an increased risk of suicide. Interestingly, in the bladder cancer group, patients that underwent cystectomy, they still had a higher SMR for undergoing surgery, but it was the only treatment group that had a higher SMR for receiving surgery versus not receiving surgery. Both were still relatively high. I mean, having a cystectomy was 3.54 SMR, whereas it was 2.66 for the group that did not receive it. Now, the majority of the data that we talked about excludes patients with a history of mental health illness, and that's not always practical because I mentioned earlier on, 20% of patients will have mental health illnesses going into life, essentially, when they see you. So this is a study done in Ontario that looked at patients with solid organ malignancies who had a history of mental illness, and they assessed pre-cancer psychiatric utilization on cancer-specific mortality and all-cause mortality. And this is basically psychiatric utilization grade, where 0 was no utilization, 1 was they had outpatient psychiatry previously, 2 previous emergency department for psychiatric purposes, and 3 they required admission for psychiatric purposes. And they performed a multivariable analysis on cancer-specific mortality, adjusting for age, gender, comorbidity score. This is a very ugly slide, and I apologize for it. I couldn't figure out a way to make it look a bit nicer. But basically, there was 676,125 patients, 52% of which had a PUG score of 0. There was 45% of patients had PUG 1, 1.2% PUG 2, and 0.6% PUG 3. They found an analysis that those with higher PUG were generally younger, female, had more comorbidity, and lower income under analysis. But interestingly here, they found that increasing the PUG score was an independent risk factor with worse cancer-specific survival on multivariable analysis. And of those patients that died, the higher PUG score was also associated with earlier time of death. And furthermore, increasing PUG was independently associated with worse all-case mortality rates. These are the prostate, bladder, and kidney findings. And interestingly, kidney was the one cancer that was not affected in terms of increasing PUG scores, but you can see prostate and bladder, along with all other solid organ malignancies, were significantly impacted. So it's important to know the patient's mental health history when discussing with them their cancer diagnosis, because as you can see, having a predisposed mental health concern is a risk factor for them moving forward in terms of treatment. And you might think, well, those are high, very intense surgeries, intense diagnoses, and so does it matter if you have a smaller diagnosis or if they need a quicker surgery? And so I'm just going to deviate just to hit home the point that it is important to know their mental health history, because this is a study that was done in patients that were receiving day surgery. And this isn't necessarily urologic, it's all surgeries, but patients that required day surgery. This was a study that was a multi-center, 2-group parallel, single-blind randomized control trial from October 2015 to July 2016. And the patients basically performed an SF-36 pre-op on day of surgery, and the 2 summaries were calculated, a mental component score and a physical component score. And you want it to be a higher score because that would suggest that they're better. And they were basically assessed on day 7 and day 14 after their surgeries. And you can see that multiple domains were affected at day 7 and day 14 with statistical significant findings of sleeping difficulties, not having general feeling of well-being, and multiple other domains were significantly impacted of these patients who were not in the appropriate mental health state going into the day surgery, and it impacted them thereafter. And so what they found is they found a significant lower quality of recovery in 21 of 24 items on post-op day 7 and 22 of 24 by day 14 with those that had low mental health scores pre-surgery to those that had high surgery. And this is a very key takeaway. These weren't large major surgeries, yet going into a procedure with a low preoperative mental state suggested that they have a higher likelihood of having difficulties coping with the recovery process. We do day surgeries quite a lot. And so that's why it's very important to be aware of this. So this is the hardest part to try to figure out. So what can we do as urologists? I think it's very important when we're assessing patients to do a full history, and sometimes social history isn't the thing that we're the best at. Finding out about their mental health issues, finding about their home situation. Are they single, divorced? Are they married? Because we know those are risk factors. They're obviously comorbidities are very important, because the more comorbidities you have, the higher risk of mental health concerns postoperatively. And if we're following patients long-term, look for particular clues on sudden lifestyle changes, particularly in the male patients. Are they acting differently? Are they kind of going rogue? Those could be the subtle cues that there's something going on. These are the available questionnaires when applicable. And, if there's a concern, we can certainly offer these questionnaires. And if there's a red flag, then they can be forwarded to mental health experts to deal with. And so I think it's important that we're aware that these forms and questionnaires are available. And some patients may need it preoperatively to get an idea of where they're at with their mental status, to be prepared for recovery postoperatively. It's important to, and this is very challenging, because we need to have a good relationship with mental health experts to send over the referrals when indicated, and make sure that we have that they're part of the interdisciplinary team when needed. But it's challenging because it's not always easy to access mental health experts. I actually spoke to a couple of psychiatrists about this. I said, there's a patient that, they need a cystectomy, for example, but they're too anxious to have surgery. What do you do? And they said, outpatient referrals and anywhere from 3 to 12 months to see a psychiatrist, and that's simply not feasible. So one of the suggestions they actually made is, if you really need a psychiatric assessment, you should admit the patient and get an inpatient psych assessment, and that way they're in the system, they're seen by a psychiatrist, and necessary follow-up will be arranged much quicker. So it's a bit of a loophole. It's not ideal, especially during a pandemic, you're taking up a patient's bed and things like that. But I think that's something we need to work towards optimizing if we're going to have a closer relationship with the experts, because right now access is very challenging. So the last thing I'm going to talk about is this is more so for us, for the physicians. When I was looking into the literature about mental health and surgery and patients, there's not a lot of great data that talks about the surgeon or the urologist. And, it's not because we're immune to mental health concerns. It's because, perhaps we don't seek it out as often as some people may need to. 1 in 5 people have a mental health concern. And that, when you look at the literature, 1 in 5 physicians have mental health concerns. That's no different, but the difference is the physicians are 2 to 3 times more likely to commit suicide when they're in a mental health state that's not well. And so this is a program that is available basically to physicians that want to connect to mental health help. It's a 24/7 helpline for physicians that can call and speak with a registered clinical counselor, access points to other services and crisis support. And they basically offer multiple different domains of how they can help. If you need to take time off, back to work, if you're worried about a colleague, different ways that you can contact them and seek their advice, and basically do it all in a confidential manner. And so I'm leaving this for the general group, and this is their contact in terms if there was ever a way to contact them and that you were curious about. But this takes me to the end of my talk. And, in conclusion, men can be very difficult to diagnose with a mental health illness. And it's up to us to try to be as astute as possible to seek out what's going on in the patient's lives. Urologists can play a very key role in diagnosis and treatment of patients with mental health concerns. We may be the only ones that really see the signs and symptoms of patients that aren't doing well. And so we just have to be very, very cognizant of these signs and risk factors. Thorough history is very critical in new patient assessment, doing a full social history and having a good understanding of the person rather than just the patient. I think it's very important. mental health of patients plays a significant role in overall disease treatment. And we saw in both studies where they had mental health concerns before or they didn't, that once you tell them you have cancer or this is the treatment, it's not a simple pluck and grab and you're done. These patients have concerns long term. And involving the mental health experts can play an important role. And I think we need to find a way to better optimize access to mental health for these patients. If we're worried about a patient, simply waiting 6 to 12 months, I don't think is appropriate. So that's something that we need to figure out in terms of better access for the patients, because they'll have better results long term. And that's the end of my talk. Thank you.